I extend a warm welcome to all the participants for joining in this important webinar on treatment of iron deficiency anemia in cancer patients, where to discuss various aspects of that, we have today Professor Dr. GHANASHYAM, who has kindly consented to share his views on the topic. To set the ball rolling, Mr. Pankaj Srivastav, Vice President, Marketing and Training, Biotexus Pharma, will share a brief about Biotexus journey, and following that, Ghanasham sir will delve on the subject. So without further ado, I would like to hand over the proceedings to Mr. Pankaj Srivastav.
Thank you, Ria, and good evening, everyone. On behalf of Biotexus Pharmaceutical, we heartily welcome all the participants in today's webinar. And today's topic is treatment of iron deficiency anemia in cancer patients. And we are extremely privileged to have Dr. GHANASHYAM BISWAS sir for consenting to share his thoughts in this important webinar. And though I do not want to come in between you and Dr. GHANASHYAM sir, but then for just 5 minutes, I just want to share with you why Biotexus Pharma came into existence and what is our mission. Because you will appreciate when Biotexus Pharma it came into existence some 2 years back, our main mission was just to challenge the unmet medical and societal needs. Now, with that one thought, Sanat Mathi started this organization. And of course, initially we did face a lot of problems, a lot of challenges, because we launched this company and then the COVID came. But thanks to the support from the medical fraternity, I would say that the company is doing reasonably well and trying to help the patients. After mission comes the vision, because ultimately vision is also equally important for any organization to thrive. And I'm extremely happy to share with you that our vision right now is in oncology, to support our cancer patients. And we also need to redefine the cancer treatment paradigm with our newer medicines, what we have been introducing. And of course, we turn ideas into life-changing medicines, because these ideas, of course, we get from our doctors only. And based on their suggestions, of course, we have been coming out with our new products. Now, you will appreciate any organization is known for its values, right? Because it's very important what values the organization has. And as far as Biotexus Pharma's values are concerned, well, first value is, of course, innovation. Because in this competitive world, it's very important that we must come out with innovative strategies, innovative products in order to thrive well. And therefore, we have kept first value as the innovation. Then, of course, comes the confidence. Confidence in our company, confidence in our products, confidence with which we communicate our products to the medical fraternity. Third is, of course, the respect with all the stakeholders, with the doctors, with our channel partners, because the respect is something which is extremely important, and it is then the core of any organization. So we have decided that we will maintain this respect as one of the core values. Then solidarity, because you will appreciate, if you want to surmount any challenge, if we have got the solidarity with the organization, we will be able to surmount that. And lastly, of course, comes the customer delight, because this is something which is extremely important for everyone, because one thing what we promise, that if there's something which we have promised to the customers, we try to complete that within that stipulated time. So this is how at least we try to deliver our customer delight. Now, with this, you might be wondering as to what our organization is all about. So basically, we want to provide the best quality standard drugs. And these drugs, they adhere to the good GMP, good manufacturing practices. We also try to come out with novel and differentiated scientific solutions. And lastly, come out with innovative products. Now, though we are a nascent organization, but I'm glad to share with you that, we also try to do something in our own little way as towards the corporate social responsibility. So some of the things what we have undertaken as a company is like tree planting, child education. And when Amphan actually hit that, in our, I would say, nimble ways, we tried to support our families who suffered due to this Amphan. Now, lastly, I would only like to say that our current product range, which is growing day by day, we have got Texpur, which is iron plus polysaccharide, Texpro, which is a whey protein supplement, Texner, which is methylcobalamin plus pyridoxine, Texcurmin, which is curcumin, and there we have got both the formulations. parsley, which is tocotrienol, and TexQ10, which is coenzyme Q10. Now, with this, and of course, bioplate, which is a carica papaya extract, along with many other things to increase the platelet counts. Now, lastly, with this, we close our as far as company introduction is concerned, and I'm extremely happy to take this opportunity to welcome Professor GHANASHYAM sir. His CV runs in 25 pages. And I can only say I was finding it very difficult to condense this because there was so much to share, at least for a person who is sitting in Bangalore. I was quite amazed to see that in Bhubaneswar, we have got such a person who has done so much in the field of cancer treatment. Now, still, just it's a formality, but still let me do that. So as far as Professor GHANASHYAM sir is concerned, he did his MBBS in 1995 from SCV Medical College, Cuttack. He did his MD in 2000 from MKCG Medical College, Behrampur, Odisha. He did his DM from Tata Memorial Hospital, Mumbai in 2005. And sir has been associated with so many organizations. There are plenty of organizations like API, OSO, ICON, ISO, and so on. And also, he has indexed, publication as high as 40. He has clinical trial experience of 46 clinical trials. Imagine for one clinical trial, 2 clinical trials, it takes years together. And he has got such a robust experience of 46 clinical trials. Society recognition, 18 societies have recognized Professor GHANASHYAM sir. And of course, he has been having a clinical practice of 17 years. The list doesn't end here. He has been associated with so many other important, I would say, responsibilities. Like, for instance, he is an executive director for Sparsh Hospital. He is a DM faculty for SUM Hospital, member institute committee for stem cell research, All India Institute of Medical Sciences, Bhubaneswar, member Biosafety Institute of Life Science, founder president, Asian Nutrition Society, secretary, Odisha Society of Oncology, joint secretary, Templicity Onco Club, founder and CMO, Swast Bhumi Private Limited, and president, International Association of Oncology. I think, ladies and gentlemen, I think we are extremely privileged as far as Biotexus Pharma is concerned to have sir as one of our faculty to share on this important topic. So without much ado, sir, I hand over the stage to you. And I will stop sharing my screen.
Good evening, everyone, and thank you, Pankaj, for those kind words and introductions. Thanks, Sanat, thank Kishore, and the whole Biotexus team. Are you able to see the slides and I am audible?
Yes, sir.
There are lots of background noise, so I think please let us
now it's okay. Fine, sir.
I think need to mute others. Right. So in fact, so cancer nutrition and cancer anemia was a neglected subject, and the neglect was not only from the caregivers and from the industry also. I think for last 1 decade or so, the importance of cancer-related anemias and nutrition has come into importance, and that's how there are so many players you see today. So the though topic was in iron deficiency anemia in cancer, but iron deficiency anemia, though it is the commonest, but it is not the only aspect of anemia that is being dealt when we talk about cancer. So there are varying aspects. So let us summarize and see so how things goes on. So anemia is a very broad term. So we have been learning since our graduation and post-graduation days. So it can be a simple thing and it can really be a fatal. So the red signs. So fainting leading to a subdural hematoma, chest pain, angina, and at times heart attack and resulting in death. So anemia can be seen in a physiological state when there is an increased demand of iron. And on the other side, so there can be because of a decreased availability of the iron. So cancer-related anemia, if you look at the incidence, so 3 out of 4 of cancer patients have anemia at some point during the diagnosis. So 2 out of 3 among solid tumors and 3 out of 4 in the hematological malignance will have some grade of anemia. So 40% of them, including solid and the hematological malignance, being severe enough to warrant RBC transfusions. And everybody of us who has been a caregiver understands how things were difficult in times of COVID in last 2 years arranging for an RBC transfusions. So be it a replacement or be it for a surgical requisite. So in the Indian context, these figures are likely to be higher due to the prevailing malnutrition in the general population, and that too many of us knows that. So since the toilet system have improved post-independence, but still many of us goes barefooted and helminthic infection is one of the commonest cause of an iron deficiency anemia in our population. So what are the causes in cancer? Anemia occurs due to various reasons. So it can be nutritional deficiency. It can be because of hemolysis, blood loss. The most important thing is infiltration of the bone marrow by tumor cells, especially in hematological malignancies and even non-hematological malignancies at times. So myelosuppression due to therapy, it can be chemotherapy, it can be radiotherapy, it can be combination of both. So cancer itself is an important cause of anemia that we say that is anemia of chronic diseases. So which we see in many chronic diseases in a normal practice. So other can be infections, inflammatory disease, and renal failure like CRF and ARF. So what is the importance of anemia and cancer and what it can lead to? So definitely the quality of life is compromised. The patient gets fatigue if they are at workplace. Poor performance status. So they may not follow up with you and there is a compliance issues and the treatment gets delayed. At times there are impaired cognitive functions and there is an aggravation of existing comorbidities, especially the COPDs and if somebody has a cardiac illness. Premature death because of poor tolerance to chemotherapy. These are the patients who don't tolerate a dose-dense treatment, and you land up in giving a compromised dose of treatment, be it a chemotherapy or a radiotherapy, and which ultimately leads to a tumor progression. So how do you scale your anemias in the National Cancer Institute from a mild to it can be a death? So less than 10, less than 8, less than 6.5, less than 6.5 can be really a life-threatening. So anemia and chemotherapy. So there are certain agents and the certain regimens where, and probably certain diseases too. So we know that hematological malignancies are more common than the solid tumors. But there are certain regimens or the combination of drugs where, so grade 3 and grade 4 anemia is not uncommon. So we talk about docetaxel. So almost in 1/3 of the patients, you can land up in grade 3 or grade 4 anemia. So during the various cycles. So there can be combinations of paclitaxel, which is a very common practice in cancer, be it an ovarian, breast cancers, lung cancers. So another important is a cisplatin etoposide, which is normally used in any small cell tumors or in neuroendocrine carcinomas, and especially patients of germ cell tumors. So these grade 3 and grade 4 anemias are so common. So the risk factors being that elderly patients are definitely more at risk. If the baseline hemoglobin is low, then probably these patients are at risk. So plant therapy is potentially myelosuppressive, especially if a combination of chemotherapy or high dose chemotherapy. And suppose somebody gives a history of transfusion within last 6 months or has received some form of chemotherapy, or their bones have been more than 20% of the active bones, especially the pelvic bones or the sternal bones are a part of radiotherapy field, then probably these patients may not tolerate your further therapy, and they are a candidate for a regular treatment or require treatment for the low hemoglobin. So today there are many new drugs, targeted drugs like the PARP inhibitors, olaparib. So they can cause 60% of these patients will end up with anemias and requiring some sort of transfusion or replacement therapies. So there are many other newer drugs like breast cancer, CDK4/6. So anemia and a functional neutropenia are so common in these patients who are on especially palbociclib or ribociclib. So even the newer drugs shows there are patients who can land up in a severe anemia. So how do you evaluate the patient? So this patient have been on a routine follow-up or a clinical examination shows that patient is anemic. So the basic thing to do is a CBC with all indices. So it is not only hemoglobin, WBC, platelet, and the differential count, but you need to see the retic count, MCB, MCH, and MCS. And that's why one should order RBC with indices and a blood smear morphology, that is a peripheral smear comment. And then according to a case-based, you need to do a stool local blood. Every patient should be subjected to an iron profiling, which includes a serum iron, TIBC, ferritin. And for those patients who are suspect to be a macrocytic or who are a true vegetarian at times, or an alcoholic, so definitely serum vitamin B12 and folic acid becomes important. So definitely another factor, as you discussed, so renal failure. So if serum creatinine is high, the GFR is less than 30, so that can also contribute to anemia. And there are at times you have a patients who can where probably a hemolytic component can exist. So there a Coombs test, direct or indirect, and a serum haptoglobin leveling has to be done. So once you see and document and grade your anemias in your cancer patients, so what is the goal? So definitely improve hemoglobin level, because we know that improving hemoglobin level will also improve the oxygenation. It will improve the quality of life, and it will reduce the need for RBC transfusions, because we'll see in the subsequent slide. So RBC transfusions are not an easy. So you are at risk for so many things. So that can be helpful when as an acute treatment or management, but for a chronic treatment or an ongoing patients, so RBC transfusion is not a solution, permanent solution. So how do you approach for these patients with anemia? So this is a very basic slide. So since we have been asked to discuss on iron deficiency anemia, so you can see the extreme right. So the iron stores, here in iron deficiency anemia is absolutely nil. You can see the circulating iron, so it is half filled. Look at the stored in the bone marrow, it is 0, serum ferritin less than 15, TIBC is high, serum iron is too low, and the saturation is less than 10. So then you know that you are dealing with the iron deficiency anemia. So we are talking about iron today. So I come from a steel city from Raulkela, and my father used to be a man from SAIL. So there is a bit of iron or the bit of SAIL in everybody. So that's like, so there's a bit of iron in everybody. So iron is an essential element, and iron is in the form of ferritin and hemosiderin. Most of the livers, spleen, bone marrow, duodenum, and skeletal muscle. So iron is important for functional component because it is a transporter of oxygen, and we need it for growth and development. And ultimately, it manufactures or creates hemoglobin. So hemoglobin comes from two components. Hem is Fe, and globin is a protein. so which actually transport oxygen from the lung to the various organs. So each heme group contains an iron atom that is able to bind to an oxygen molecule. So globin, the protein, surrounds and protects the heme molecule. We know that it is available as two forms. Fe2 is a ferrous heme iron, and Fe3 plus is a non-heme iron that is called a ferric iron. So around 3/4 of our body's iron is found in the red blood cells in the form of hemoglobin. The optimal adult dose of this elemental iron is something around 2 to 3 milligram per kg body weight per day. So looking at the source of iron, so on the left hand side, so many a times we see that there are true vegetarians lands up with the iron deficiency, or many a times we have seen a patient with the pancytopenia. If somebody takes matches the different sources of vegetables, so probably you won't land up in iron deficiency. It can be a tomato, it can be mushrooms, soya beans, and people who are fond of dark chocolates, they can have, and spinach is probably a part of many Indian and normal food. Animal sources of definitely the meat, the marine food, and chicken, so they can be a good source of iron. So the physiology of iron is heme iron can get directly absorbed in the intestines called the enterocytes, and this happens in most part of the duodenum and upper part of the jejunum. So where this whole physiology runs. And non-heme iron cannot get directly absorbed in the intestine, that is the ferric form. So non-heme iron, so ferric form gets converted to ferrous by varying enzymes, vitamin C, and this enzyme that is ferroreductase. So this is a diagramatic view. So once you have a food iron, so one component is a heme iron, that is a ferrous. The non-heme iron is a ferric, and the heme iron goes through the hemotransmitter, as I said, in the duodenum and the upper part of jejunum, and this non-heme iron from ferric gets converted to ferrous in the presence of certain enzymes and vitamin C. So what is important on the right hand side, you can see, so there is a protein which gets released from liver, is a hepcidin. So which is important for any chronic disease and also cancer. So usually the cancer patients or patients who have active disease, hepcidin is high, and hepcidin actually, high levels of hepcidin actually inhibits certain proteins, and that actually decreases this iron absorption and the store. So this is mentioned, the same thing is mentioned here. Inflammatory disease like cancer, hepcidin levels will increase, leading to reduced absorption and storage. So it is basically a peptide hormone produced by liver and secreted in the circulation. So this is basically a acute phase reactant which works as a negative regulator of iron absorption or the metabolism. So how do you manage? So once you have established, once you have read, once you have known the source, the reason for this iron deficiency. So the dietary advice, so you take the help of your nutritionist. Then the commonest thing what we do have been doing for last so many years is an oral iron. Now there are, because the gynecologists used to IM iron, now IV iron is in rampant use for amongst the oncologists and even the gynecologist. And of course, blood transfusion has been there, and we know that is the best solution for a acute management. So dietary advice and the oral iron looks like it's a cheaper options and an effective options. I mean, it has been there for so many years, and we know that. So not everybody is a candidate for oral, not everybody is a candidate for the parenteral form. So these are certain 5 types, you can say, of oral iron. Like the intravenous iron, we'll see there are 3 generations. So we can also have these 3 generations of oral iron. The first one is a ferrous salts. It can be So one of those common during our MBBS and MD days is a ferrous sulfate, then gluconate, then fumarate and aspartate. Then came the ferrous bisglycinate and then ferrous ammonia citrate. Then we entered into some newer formulation like carbonyl iron, then moved into heme iron polypeptide, and today we are discussing about the iron polysaccharides, so the complex. So what Biotexus is promoting, the text per 150 milligram. So that's the encircled one. So polysaccharides are the most abundant carbohydrate found in food. They are long-chain polymeric carbohydrates composed of monosaccharides. So carbohydrate can be in the form of starch, cellulose, or glycogen, whose molecules consist of a number of sugar molecules bonded together. So we will see in the subsequent slide also, so why this is important. So many polysaccharides are used to store energy in organism, which can provide structural support to the body and cellular communication signals. While the enzyme that produces energy only works on the monosaccharide stored in the polysaccharide, but these polysaccharides typically fold together and can contain many monosaccharides in a dense area. So this can be a natural sources like the cereals, like the oats, pasta, and small amount in other root vegetables. So the mechanism of action is when iron is combined to polysaccharides, the porphyrin and globin chains form this hemoglobin. So these polysaccharide iron complex are best observed and often considered the standard compared with other oral forms of iron, that is usually the ferrous salts. This polysaccharide iron complex is the best and probably helps to convert blood sugar to energy, so which is required. So how this iron polysaccharide differs from the regular or the conventional or those ferrous sulfates we have been using for ages now. On the left hand side, we can see iron polysaccharide complex more effective in improving hemoglobin concentration rapidly and in a sustained manner. It can be used in infants and young children with nutritional deficiency, so which is less effective in regards to a ferrous one. So iron polysaccharide contains many monosaccharides which produces energy. So not many monosaccharides in the ferrous sulfate, so the energy concept is not there. Iron polysaccharide is a high absorption rate, is a low absorption in case of ferrous sulfate. So polysaccharide combination is a stable complex, and we know that ferrous sulfate is not a very stable composition. So the polysaccharide released in the intestine duodenum. So that's why we don't see much of GI toxicity regarding that dyspepsia or vomiting. And in ferrous sulfate is released in the stomach, hence all the cardinal signs of all oral iron toxicities, starting from constipation, dark stools, so whatnot. So the text per 150, which is marketed by Biotexus, is iron plus polysaccharide. So B for urine, B for iron. So Biotexus brings better bioavailability. So that's 4B for you for the text per 150, that is iron plus polysaccharide. So this formulation can be taken orally, especially for iron deficiencies, and is a component of hemoglobin and many enzymes in the body necessary for transfer of oxygen. Absorbed in the intestine, usually taken 1 hour before or 2 hours after meal. If stomach upset occurs, may take these medications with food. So we need to remember that most of the irons we need to avoid antacids and the dairy products, or consumption of tea or coffee within 2 hours before or after medications, because they might decrease the metabolism and thereby the effectiveness. Is well tolerated when enters the stomach because it is not released there, and there is no chance to react with the acid in the gut from the hydroxyl radical. So as I discussed, it is a more stable as compared to the ferrous sulfate because of the polysaccharide, which contains many monosaccharide components which actually produce energy. So usually we offer 1 capsules daily. At times the patients, so you may consider twice. So it definitely contraindicated for those patients who doesn't have a documented iron deficiency anemia, or the anemia or is of a different cause, and patients who have high hemoglobin or hematochromosis or hemocytosis. So definitely you are not going to use that. For those patients who are constipated, who have a profound diarrhea, nausea, vomiting, so probably, so all these oral irons, so be it a polysaccharide or a ferrous sulfate, so will be a relatively contraindicated. So at times you may land up with overdoses of iron. So that can be detected from clinical findings or from the blood parameters. So the bioavailability is good. So you can, so once there's a documented anemia, so the patient should receive 1 capsules daily for 3 months, and that shows excellent response. So in this summer, when Odisha is almost fighting with 45 degrees for last more than a year, more than a month now, so the storage should be relatively in a 25-degree, so that you can avoid the higher temperature. It doesn't mean that you need to keep it in the fridge, but definitely, so not at these 45 degrees when, so there can be issues with the drug. So oral iron traditionally has been with problems, especially with the older generations, because most of this older generation had a GI symptoms, constipations, and many pregnant lady receives it, and the worst constipation is during pregnancy. So you'll require it at least for the 3 to 6 months. So many of these, all ferrous and ferrous, so twice daily. And as I said, so ineffective with primary gut issues. So patient who has continuous dyspeptic symptom, nausea, vomiting, diarrhea, constipation, so may not be a candidate for oral iron. And somebody who has a bleeding to iron deficiency may not be a much effective drug. So whom to consider for transmission? So especially for you are planning for a surgery, a patient had come to you with a bleeding episode, so probably the patient in a congestive cardiac failure, so we need to give transfusions slowly and under monitor, and these patients will require lots of diuresis too. So RBC transfusion, many of us, especially our fraternity people, thinks, especially patients who gets treated in the periphery, so blood transfusion is easy, but it doesn't, it comes with a huge risk also. So the benefits are that the rapid increase is there, so rapid control of symptoms, and you don't require the erythropoietin stimulating agents, but the risk can be at these are especially cancer, an active cancer disease when not in control, you know that. So there is a their thrombotic chances are much more, and so you cannot be sure that your transfusion is not going to transmit any other viral infections. So there are candidates who will be benefiting with an injectable iron. So these are certain iron profiling. So where you need to do the need to see the serum iron, the ferritin, and the saturation, and decide on the iron profiling. If somebody is going for an aggressive chemotherapy, somebody is going for planned for a surgery. So like oral iron, so there are now 3 generations of IV iron. So the first generation being an dextran, iron dextran, low molecular weight and heavy molecular weight. The second generation can be ferric gluconate and iron sucrose. So today the oncology fraternity is more moved into a third generation like the ferric carboxymaltose and ferric isomaltoside. So there are formula, the Gajonis formula for calculating the total iron dose. So you need to know the baseline iron. If your target volume is something on 15, then you are going to calculate on this formula. So anemia of systemic disease, so especially for those patients with advanced cancers, so where you know that these patients will be on n number of systemic therapies today and in future. So this is known as anemia of cancer, or as we discussed, so where the FCD levels are quite huge. So these are the patients where they are benefited with oral iron and IV iron. There are individuals who have a restless leg syndrome. So we know that this is because of some disorders in the substantia nigra. And once you document it, so you'll see that these patients have lower levels of ferritin and transferrin, and they beautifully respond to iron, especially the parenteral iron. So if parenteral iron is not possible, then definitely the oral form of any of these irons. So that's from my end. So I'll be happy to take any questions. So I've been using this textbook for now almost 7-8 months or a year. So definitely, so my patients are almost on this for 3 to 6 months till the iron gets replaced in the store. So thank you so much for a patient hearing on a Saturday evening.
Thank you, sir, for taking us through this presentation. I must say it was extremely nice, lucid presentation where, Dr. You have highlighted the incidence of anemia in cancer patients, the reasons for that, why this anemia is there, where you have highlighted hepcidin levels and high hepcidin levels, etc. You have also highlighted what are the various types of irons and how it gets absorbed, and of course the various generations of iron. You have also highlighted where the doctor should think about giving the parenteral iron also very clearly, and what are those conditions where parenteral iron cannot be given and then oral iron could be given. So, sir, once again, thank you on behalf of Biotexus for taking us through. And sir, you have also shared your experiences. The floor is open for any questions, sir. We still have got 15 minutes, rather 10 minutes, 11 minutes to go, because 6:30 I have to leave, sir. So we can utilize this time for any interaction. Any comments?
So somebody has asked for a role of erythropoietin. So definitely, so these are a group of erythropoietin stimulating agents. So there are 2 drugs now. So erythropoietin and darbepoetin. So the role of erythropoietin and darbepoetin is restricted in cancer to only a palliative setting, because so there is a black box warning and or there is a concern in a curative setting. Suppose a breast cancer patient receiving an adjuvant chemotherapy, or a stomach cancer or a colon cancer receiving an adjuvant chemotherapy. So these are the patients in a curative setting. So definitely there is no harm in giving oral form of iron, so be it a Texper or the IV iron. But these are the patients where you are not going to use erythropoietin and darbepoetin. But for all palliative settings, so darbepoetin and erythropoietin can be used, because we know that so up to 100 to 150 milligram per kg body weight you can use. So normally, like in a nephro setting, we see the patients take erythropoietin 2 units, 3,000 units, 4,000 units every weekly twice or something like that. But darbepoetin can be given 100 microgram every weekly, 200 microgram every 2 weekly, and now even Dr. Reddy's has come out with a 500 microgram. We have published a paper also. So that is can be given every 3 weekly, because most of the chemotherapy cycles are 3 weekly. So you can use darbepoetin. So restricted only to a palliative setting. Suppose you are treating a metastatic breast cancer, colon, or a metastatic stomach cancer. So then you can always, in those patients where you see the iron levels stores are good enough, but still the patients are anemic. So these are the patients where there is a role now. Otherwise, in hematological malignancies like and the MDS, myelodysplastic syndrome, so we do a baseline erythropoietin levels. If they are low, so definitely they are candidates of erythropoietin and darbepoetin.
And sir, I am curious to know one thing, that now that you have been using Texfer, as you have said, what has been your experience after how many days you find increase in the hemoglobin count?
Because once you're using IV iron, no, the patient comes to you weekly. But in the oral iron, so we don't call these patients so frequently.
Okay.
So unless and you do a prospective study or a cohort, then otherwise most of these patients, they come after 2 months or 3 months. So we actually don't know if this rise in hemoglobin has happened over weeks or it has happened over months. So unless you do a prospective 10 patients, 20 patients, and then probably we can answer that.
Thank you, sir. Thank you. Any other questions, sir? Any other doctor would like to ask? Any comment? And sir, there was one more question which when you were sharing, those patients where the serum creatinine is high and eGFR is low. I know that many nephrologists, they give, these iron supplements. So will you suggest that iron plus polysaccharide could also be given in those patients?
Yes, yes. So there is no contraindication. So there are always a relative contraindications because those patients who are into a renal failure, they have a component, especially if they are in azotemia, they have a lot of GI issues because in a renal failure, the stomach, there is a gastropathy. So there is a vascular gastropathy. Yes. So that can probably these patients may not be able to. If the patient is otherwise not much of dyspeptic symptoms, absolutely they can be given.
Thank you, sir. Thank you. Okay. Any comments from anyone, sir? We have got a few very senior doctors also. So would you like to say something, sir?
So how is the weather in Bangalore? So here it is.
Bangalore, sir, it is raining outside.
Really?
So it has been raining every day here. So I mean, sometimes it rains so much. I wonder whether I'm in Chira.
Rain is not there. We are wanting for rains and it is not there.
And here it is raining so much that sometimes it becomes very scary also because our drainage systems are not so good, so well equipped to handle this.
But this year, throughout the country, the heat wave has been
very bad.
Extremely
very bad.
So the Delhi has touched 49 plus, and in many of the parts of Western Odisha, they have. So there we see every time. So it is 48, 49, 50 touching 50.
True.
In Mumbai also this year, so extreme hot.
Very high, very hot. True. So, well, if there are no questions, I'll request Ria to propose the vote of thanks.
Dear doctors, on behalf of Biotexus Pharma, I would like to thank you for your valuable time on Saturday. I also would like to specially thank Professor GHANASHYAM sir for enlightening us on such an important topic which impacts our cancer patients. I also would like to thank Sandeep sir for helping us in organizing this webinar and providing all crucial support. I do hope that this discussion was very helpful in deciding and helping the cancer patients suffering due to anemia. Thanking you once again for your kind presence. Good night and take good care of yourself.
Thank you, sir. Thanks a lot for your presence.
So much, sir.
And we are well within our time because I was very careful about we shouldn't exceed 6:30 because you have got another appointment.
Thank you so much. Thank you.
Thank you, sir. Good night. And thank you, everyone.